India is the diabetes capital of the world. Cardiovascular problems are very common in diabetics. In fact, what I would say, a normal artery of a normal person who is non-diabetic is like silk. Nothing sticks to it, nothing passes through it. But the artery of a diabetic becomes like Velcro. Everything is very sticky. And hence, the risk of cardiovascular problems increases in diabetes. There are various medications that we use to improve or reduce the cardiovascular risk in diabetes. One of them being statins, been very commonly used. But even despite that, even controlling the cholesterols, we are trying very hard. Despite that, there is an increase of myocardial infarction and cardiovascular disease. To counter that, we have a new medication in the market which is called PCSK9, which has been recently launched in India. To throw more light on that, we have with us Dr. Ramachandran from UK. Sud was my mentor in UK. In fact, whatever I've learned in diabetes and whatever wrong I do, I can blame it onto him as to whatever I'm practicing in India. So Sud, can you tell us about PCSK9 and how it helps?
Yes, I can. We've been very lucky in the United Kingdom to have access to PCSK9 inhibitors over the past 2.5 years. They were licensed in 2015, and what is important is that at the moment we'll try to lower LDL cholesterol far more than what we can do with conventional oral agents such as statins and ezetimibe. This is called the lipid hypothesis, and at the moment we don't have a lower end. And PCSK9 inhibitors, unlike statins, they're very efficacious but have far fewer side effects. So our experience is very positive. In the United Kingdom, it is funded by the NHS for patients who are at high risk. I wish the price was lower because it really would be wonderful to treat most of our patients. We can get them down to levels where we significantly lower their cardiovascular risks.
So there's always this discussion about the medication is expensive, it may not be affordable, it is not for our country. In India, people will say that it's going to cost a huge amount of money. But I think a balance has to be struck between a quality of life, A, and B, if you can prevent a myocardial infarction, if you can prevent another stent being getting into the body, that itself is expensive, and plus the medication that you ought to take after. So what do you think of the balance of the equation here?
That's actually a very difficult one, because the balance to the individual affected is going to be very different from, say, the administration who have to put the money forward. It's more complicated in the United Kingdom because it is centrally funded through general taxation, where the patient does not have to pay for it. So NICE, who make the recommendations, look at aspects like quality adjusted life years, and they have a cutoff, and when it's above or when it's below, I think it's about 20 or 30,000 pounds to prevent one event, they would agree to the funding. So effectively, high-risk patients get it. But with more and more evidence coming out, you probably would find that the quality drops, and it'll be prescribed to more patients and do a lot more good.
So tell me one thing. 40,000 rupees per month, around that, I presume, is the figure that's going to be when they're going to launch it in India. Around 5 lakhs a year of cost to the patient, versus the cost of the stent. We know the price of stent has come down in India now. It's around 30,000-35,000, a ballpark figure. What do you tell our physicians? When should the penny drop for them to think, look, let's put this on PCSK9. Let's consider PCSK9 for this patient.
I think it's very different from the United Kingdom, where it's centrally funded. Over there, because it's funded by the NHS, you look at a certain risk threshold. What's interesting is it is not £200 an injection. That's what you would purchase privately. The NHS gets it at an undisclosed price reduction, and that's really what it came about. When it was the equivalent of £200 plus per injection, we actually couldn't use it. So the first year post-license, in the NHS, we were not allowed to use it. But when you come into a country, I mean, I was born in Sri Lanka, and again, we don't have a system such as the NHS over there. It comes down to what is it worth to an individual. Now, if I was the patient, I would want it. Now, in our experience, we find that post-statin, post-ezetimibe, the LDL cholesterol drops from about 5 on average to about 2.3, a 55% reduction. Now, we know from the lipid hypothesis that a 1 millimole reduction in LDL cholesterol equates to approximately between 20 and 25% reduction in cardiovascular disease. So you can do the maths. So the higher the baseline risk, the greater the benefit. But what is the benefit to you? It depends. It obviously depends on what your income, how much you would feel that money. But it really is individual based.
So we put somebody on PCSK9, we're starting this PCSK9. Do you want them doctors to reduce the statins, reduce the fibrates, reduce the ezetimibe, or on top? Well, because they would be on the maximum tolerated dose of statins.
Yeah. Usually, I mean, in our experience, but this may be a UK phenomenon, there's statin intolerance, and most of the patients have gone on PCSK9s because they have to be high risk, and the LDL cholesterol has to be either above 3.5 or 4 millimoles per liter. That depends on their risk.
I'll stop you there. Can you tell the audience the conversion rate for them to think about it? Yeah.
Yes, 1 millimoles per liter is about 38.7 milligrams per deciliter. So effectively, many of these patients can't tolerate statins or ezetimibe, and the PCSK9's tolerability has been exceptional.
Okay.
Out of about 60 patients, I've had to stop about 3 or 4 of them.
So most of these patients are not on statin or are intolerant of statin?
Most of these patients, but that is because we are using a cutoff, a threshold of 4 millimoles per liter in most cases, in some 3.5. But if you bring that down to 2, you would actually use it more in addition to statins, in addition to ezetimibe, and they work brilliantly well.
What would be your suggestion? We've got 2 companies who are launching it in India. How do you think they should do it, that we can get more data, more research, so that we can use it, and more support system for them to use it, for the physicians to use it in the right way?
There is outcome data. With evolocumab, we have the Fourier study, and the Fourier study, now there's been a subgroup analysis in the diabetic patients, and it is significant. It is in line with the lipid hypothesis, which I mentioned earlier. Alirocumab is the other agent, and the Odyssey outcome study was published a few weeks ago, and that again shows benefit, again in line with the LDL theory or the lipid hypothesis. So really, I would like, if I was a patient, I would like my LDL cholesterol well below 1.5. I really would, because there have been some studies previously, albeit angiographic studies, which have even shown regression. We're not talking here about slowing progression, but in some cases there has been regression. The lower is better.
So let me throw here something, throw the exercise component here. What does exercise do for our viewers? How does it work? And which cholesterol?
In my experience, aerobic exercise is fantastic in patients with the metabolic syndrome. The metabolic syndrome is, I consider, a pre-diabetic state, but effectively there are criteria. And in the pre-diabetic state, exercise, diet works wonders. I think you should focus on these lifestyle areas rather than going straight on to medical management. Well, I would consider lifestyle management being part of the medical management. I think I've probably told you, I do more for the diabetic patient in my metabolic clinic than perhaps in the diabetes clinic, because you pick them up early, you can actually prevent the conversion, or let's put it, prolong the time for the conversion to diabetes. That's really where it comes.
So if I take the mantra of our discussion on this topic, basically we are saying hit hard with exercise, hit hard with diet, put them on statins. If they have high cardiovascular risk after that, or if they got a myocardial infarction, if they meet the criteria for PCSK9, do consider it, but then the other parameters have to be ticked off nicely, otherwise you're not giving him value for his buck.
You have to actually take a holistic approach, especially in patients pre-diabetes, diabetes. You look at the entire myriad of complications and then treat each one aggressively. You may fix on an order, and that depends on patient compliance, but it's really absurd to look at one aspect. And that's really what the metabolic syndrome is all about. And lifestyle is major, especially early on.
So I'm going to move you to another talk that you have given on today, and that the talk is on effect of fibrates, practical tips, because fibrate is going out of fashion, because the moment we have to hit with a cholesterol high, we hit with a statin, we do diet control. So I want you to tell the viewers, A, when to use a fibrate, what are the practical pearls in clinical practice to watch out for when using a fibrates, and which fibrate to use.
Right, that's very interesting, because since 2010, fibrate use has really dropped alarmingly. And that's due to evidence. Now, my personal view is that the inclusion criteria in some of these randomized controlled trials was too narrow. There has been some subgroup analysis which have shown that in the metabolic syndrome, those who have high triglyceride levels and a low HDL cholesterol level, they do get benefit. Now, in the United Kingdom, we go by the NICE guidelines, and my personal view is that it doesn't represent fibrate treatment as well as it could. They use triglycerides of 10, and again, I would say 10, you have to multiply that by 88.6 to get milligrams per deciliter, or 20 for action. Although they acknowledge that the subgroup analysis did show benefit. And one must remember, guidelines are guidelines. In the end, it's you, the clinician, who really makes that decision. So, yes, if the triglycerides are high, we often use a fibrate, often in addition to a statin. We don't use a fibrate as an HDL increasing agent, but I find it very useful. We have had some brilliant results with them.
There is some worry about fibrates and kidney function. Throw some light on it.
Right. There are a group of patients where the creatinine, which is a marker of renal function, from which the estimated GFR is calculated, gets worse. This is reversible. It can be a class effect because at the moment we use two fibrates, fenofibrate or bezafibrate. We tend to use fenofibrate as, in our experience, it's slightly more efficacious. Bezafibrate can have some benefits, especially in the diabetic, but you stop the fibrate and the creatinine returns to normal, the eGFR climbs. This is a subgroup of patients. We have found some characteristics which may identify this subgroup, but they are minor. It's important in diabetics to know about this phenomenon, because if the renal function drops, you may, if you are unaware of it, you may stop other diabetic agents like the new SGLT2 inhibitors, or for that matter even metformin. So the first thing is to look at fibrates, stop it, reduce the dose, or change the fibrate. It doesn't have to be a class effect, and you'll be fine.
So wait for 4 to 6 weeks, and it might take that much of time for the renal function to come back?
Give it time. 4 weeks, yes. I mean, we sometimes do blood test after 4 weeks, perhaps 8 weeks, and then make your mind up.
Okay. One more question here. Liver function and fibrate. I know we did some data when I was in England with you. Do you want to tell the people about NAFLD and fibrates?
Right. In the United Kingdom, we have a major problem in patients with the metabolic syndrome and diabetes. Both conditions are associated with non-alcoholic fatty liver disease, which can progress on to steatohepatitis and cirrhosis. Now, when we were there, we looked at quite a few of our patients, and we found that fibrates improved liver function tests. Unfortunately, no other group has shown this, so we can't use fibrates for this condition. It's probably a bonus if it does happen. Unfortunately, we couldn't carry out liver biopsies in our patients, but my suspicion is that it's an improvement in the fatty liver disease spectrum.
So what you're telling us is fibrates cannot be used for NAFLD, it's not indicated, but if you're using it for some other the licensed indication, it may improve the NAFLD that may be there. Yet
It could.
It could. So
It
something
could.
to think about there. I understand now you're doing a lot of work on new work on hypogonadism, testosterone, and even PD5 inhibitors. Do you want to tell us in brief about what's new on the market?
Right. Most of our work on hypergonadism or late onset testosterone deficiency, as it's called now, is in the diabetic patient. Now, we work closely with a good friend of yours, Professor Hackett, and our work has shown that having low testosterone in diabetics increases the mortality significantly. We had a group of 857 patients, and 382 of them had total testosterone levels that were low. The mortality rate was 16.9% over a 4-year period. We had 175 patients with the same similar baseline characteristics. We treated them with testosterone, and the baseline characteristic the mortality rate was below 4%. Massive drop. We also showed that PD5 inhibitors, Viagra-like substances, Viagra, Cialis, etc., also reduced mortality independently. And we published, and what is really required is a randomized control study.
On a lighter tone, so you've landed in Ahmedabad yesterday. You're moving around without your wife. I cannot really understand the reasons. Can you put some light on that?
My wife has actually accompanied me,
Okay.
but she's doing what she actually thinks is far more interesting. Yeah,
So she's doing your shopping bills going up.
I presume so.
It's really nice catching up with you.
And you.
Take care. Bye-bye.
Thank you.